Lewis's Medical Surgical Nursing, 11th edition, Chapter 66, Shock, Sepsis, and Multiple Organ Dysfunction Syndrome. Shock, Systemic Inflammatory Response Syndrome, or SIRS, sepsis, and Multiple Organ Dysfunction Syndrome, MODS, are serious and interrelated problems. Shock is a syndrome characterized by decreased tissue perfusion and impaired cellular metabolism. This results in an imbalance between the supply of and demand for O2 and nutrients. The exchange of O2 and nutrients at the cellular level is essential to life. When cells are hypoperfused, the demand for O2 and nutrients exceeds the supply at the microcirculatory level. Ischemia can occur, leading to cell injury and death. Thus, shock of any cause is life-threatening. This chapter gives an overview of the different types of shock, SIRS, sepsis, and MODS, and the related management of each. Shock. Classification of shock. The four main categories of shock are cardiogenic, hypovolemic, distributive, and obstructive. Although the cause, initial presentation, and management vary for each type, the physiologic responses of the cells to hypoperfusion are similar. Cardiogenic shock. Cardiogenic shock occurs when either systolic or diastolic function of the heart's pumping action results in reduced cardiac output, CO, stroke volume, SV, and BP. These changes comprise myocardial perfusion, further depress myocardial function, and decrease CO and perfusion. Causes of cardiogenic shock are shown in Table 66.1. Mortality rates for patients with cardiogenic shock are around 50%. It is the leading cause of death from acute myocardial infarction, MI. The heart's inability to pump the blood forward is called systolic dysfunction. The inability results in a low CO, less than 4 liters per minute, and cardiac index, less than 2.5 liters per minute per meter squared. Systolic dysfunction primarily affects the left ventricle since systolic pressure is greater on the left side of the heart. The most common cause of systolic dysfunction is acute MI. When systolic dysfunction affects the right side of the heart, blood flow through the pulmonary circulation is reduced. Decreased filling of the heart results in decreased SV. Causes of diastolic dysfunction are shown in Table 66.1. Figure 66.2 describes the pathophysiology of cardiogenic shock. Whether the first event is myocardial ischemia, a structural problem, e.g. valvular disorder, ventricular septal rupture, or dysrhythmias, the physiologic responses are similar. Patient has impaired tissue perfusion and cellular metabolism. The early presentation of a patient with cardiogenic shock is similar to that of a patient with acute decompensated heart failure, HF. The patient may have tachycardia and hypotension. Pulse pressure may be narrowed due to the heart's inability to pump blood forward during systole and increased volume during diastole. An increase in systemic vascular resistance, SVR, increases the workload of the heart. This increases myocardial O2 consumption. On assessment, the patient is tachypnic and has crackles on auscultation of breath sounds because of pulmonary congestion. The hemodynamic profile shows an increase in the pulmonary artery wedge pressure, POP, stroke volume variation, SVV, and pulmonary vascular resistance. Signs of peripheral hypoperfusion, e.g. cyanosis, pallor, diaphoresis, weak peripheral pulses, cool and clammy skin, delayed capillary refill, occur. Decreased renal blood flow results in sodium and water retention and decreased urine output. Anxiety, confusion, and agitation may develop with impaired cerebral perfusion. Hypovolemic shock. Hypovolemic shock occurs from inadequate fluid volume in the intravascular space to support adequate perfusion. The volume loss may be either an absolute or a relative volume loss. Absolute hypovolemia results when fluid is lost through hemorrhage, GI loss, e.g. vomiting, diarrhea, fistula drainage, diabetes insipidus, or diuresis. In relative hypovolemia, fluid volume moves out of the vascular space into the extravascular space, e.g. intracavitary space. We call this type of fluid shift third spacing. One example of relative volume loss is fluid leaking from the vascular space to the interstitial space from the increased capillary permeability, as seen in burns. Whether the loss of intravascular volume is absolute or relative, the physiologic consequences are similar. The reduced intravascular volume results in a decreased venous return to the heart, decreased preload, decreased SV, and decreased CO. A cascade of events results in decreased tissue perfusion and impaired cellular metabolism, the hallmarks of shock. The patient's response to acute volume loss depends on several factors, including extent of injury, age, and general state of health. The clinical presentation of hypovolemic shock is consistent. An overall assessment of physiologic reserves may indicate the patient's ability to compensate. A patient may compensate for a loss of up to 15% of the total blood volume, around 750 milliliters. Further loss of volume, 15 to 30%, results in a sympathetic nervous system, SNS, mediated response. This response results in an increase in heart rate, CO, and respiratory rate and depth. The decreased circulating blood volume causes decreases in SV, central venous pressure, CVP, and POP. The patient may appear anxious. Urine output begins to decrease. If hypovolemia is corrected by crystalloid fluid replacement at this time, tissue dysfunction is generally reversible. If volume loss is greater than 30%, compensatory mechanisms may fail, and immediate replacement with blood products should be started. Loss of autoregulation in the microcirculation and irreversible tissue destruction occur with loss of more than 40% of the total blood volume. Common laboratory studies and assessment that are done include serial measurements of hemoglobin and hematocrit levels, electrolytes, lactate, blood gases, mixed central venous O2 saturation, SVO2, and hourly urine outputs. Distributive shock. Neurogenic shock. Neurogenic shock is a hemodynamic phenomenon that can occur within 30 minutes of a spinal cord injury and last up to 6 weeks. Neurogenic shock related to spinal cord injuries is generally associated with a cervical or high thoracic injury. The injury results in a massive vasodilation without compensation because of the loss of SNS vasoconstrictor tone. This massive vasodilation leads to a pooling of blood in the blood vessels, tissue hypoperfusion, and impaired cellular metabolism. In addition to spinal cord injury, spinal anesthesia can block transmission of impulses from the SNS. Depression of the vasomotor center of the medulla from drugs, e.g. opioids, benzodiazepines, can decrease the vasoconstrictor tone of the peripheral blood vessels, resulting in neurogenic shock. The classic manifestations are hypotension from the massive vasodilation and bradycardia from unopposed parasympathetic stimulation. The patient may not be able to regulate body temperature. Combined with massive vasodilation, the inability to regulate temperature promotes heat loss. At first, the patient's skin is warm due to the massive vasodilation. As the heat disperses, the patient is at risk for hypothermia. Later, the patient's skin may be cool or warm depending on the ambient temperature. Poikilothermia, taking on the temperature of the environment. In either case, the skin is usually dry. Although spinal shock and neurogenic shock often occur in the same patient, they are not the same disorder. Spinal shock is a transient condition that is present after an acute spinal cord injury. The patient with spinal shock has an absence of all voluntary and reflex neurologic activity below the level of the injury. Anaphylactic shock. Anaphylactic shock is an acute, life-threatening hypersensitivity, allergic, reaction to a sensitizing substance, e.g. drug, chemical, vaccine, food, insect venom. The reaction quickly causes massive vasodilation, release of vasoactive mediators, and an increase in capillary permeability. As capillary permeability increases, fluid leaks from the vascular space into the interstitial space. Anaphylactic shock can lead to respiratory distress due to laryngeal edema or severe bronchospasm and circulatory failure from the massive vasodilation. The patient has a sudden onset of symptoms including dizziness, chest pain, incontinence, swelling of the lips and tongue, wheezing, and stridor. Skin changes include flushing, pruritus, urticaria, and angioedema. The patient may be anxious and confused and have a sense of impending doom. Patient can have a severe allergic reaction, possibly leading to anaphylactic shock after contact, inhalation, ingestion, or injection with an antigen, allergen, to which the person has previously been sensitized. IV administration of the antigen, allergen, is the route most likely to cause anaphylaxis. However, oral, topical, and inhalation routes can cause anaphylactic reactions. Quick and decisive action is critical to prevent an allergic reaction from progressing to anaphylactic shock. Septic shock. Sepsis is a life-threatening syndrome in response to an infection. It is characterized by a dysregulated patient response along with new organ dysfunction related to the infection. In as many as 30% of patients with sepsis, the causative organism is not identified. Sepsis and septic shock have a high incidence worldwide, with a mortality rate of 25% or higher. Septic shock is a subset of sepsis. It has an increased mortality risk due to profound circulatory, cellular, and metabolic abnormalities. Septic shock is characterized by persistent hypotension, despite adequate fluid resuscitation and inadequate tissue perfusion that results in tissue hypoxia. The main organisms that cause sepsis are gram-negative and gram-positive bacteria. Parasites, fungi, and viruses can also cause sepsis and septic shock. When a microorganism enters the body, The normal immune or inflammatory responses are triggered. However, in sepsis and septic shock, the body's response to the microorganism is exaggerated. Both pro-inflammatory and anti-inflammatory responses are activated. Coagulation increases and fibrinolysis decreases. Endotoxins from the microorganism cell wall stimulate the release of cytokines. These include tumor necrosis factor, TNF, interleukin-1, IL-1, and other pro-inflammatory mediators that act through secondary mediators such as platelet activating factor, IL-6, and IL-8. The release of platelet activating factor results in the formation of microthrombi and obstruction of the microvasculature. The combined effects of the mediators result in damage to the endothelium, vasodilation, increased capillary permeability, and neutrophil and platelet aggregation and adhesion to the endothelium. Septic shock has three major pathophysiologic effects: vasodilation, maldistribution of blood flow, and myocardial depression. Patients may be euvolemic, but because of acute vasodilation and shifting of fluids out of the intravascular space, relative hypovolemia and hypotension occur. Blood flow in the microcirculation is decreased, causing poor O2 delivery and tissue hypoxia. We think the combination of TNF and IL-1 has a role in sepsis-induced myocardial dysfunction. The ejection fraction, EF, is decreased for the first few days after the initial insult. Because of a decreased EF, the ventricles dilate to maintain the SV. The EF typically improves, and ventricular dilation resolves over 7 to 10 days. Persistent high CO and low SVR beyond 24 hours is an ominous finding. It is often associated with an increased development of hypotension and MODS. Coronary artery perfusion and myocardial O2 metabolism are not primarily altered in septic shock. Respiratory failure is common. The patient initially hyperventilates as a compensatory mechanism, causing respiratory alkalosis. Once the patient can no longer compensate, respiratory acidosis develops. Respiratory failure develops in 85% of patients with sepsis, and 40% develop acute respiratory distress syndrome. These patients may need to be intubated and mechanically ventilated. Other signs of septic shock include changes in neurologic status, decreased urine output, and GI dysfunction, such as GI bleeding and paralytic ileus. Obstructive shock. Obstructive shock develops when a physical obstruction to blood flow occurs with a decreased CO. This can be caused by restricted diastolic filling of the right ventricle from compression, e.g. cardiac tamponade, tension pneumothorax, superior vena cava syndrome. Other causes include abdominal compartment syndrome, in which increased abdominal pressures compress the inferior vena cava. This decreases venous return to the heart. Pulmonary embolism and right ventricular thrombi cause an outflow obstruction as blood leaves the right ventricle through the pulmonary artery. This leads to decreased blood flow to the lungs and decreased blood return to the left atrium. Patients have a decreased CO, increased afterload, and variable left ventricular filling pressures depending on the obstruction. Other signs include jugular venous distension and pulsus paradoxus. Rapid assessment and treatment are important to prevent further hemodynamic compromise and possible cardiac arrest. Stages of shock. In addition to understanding the underlying pathogenesis of the type of shock the patient has, management is guided by knowing where the patient is on the shock continuum. We categorize shock into 4 overlapping stages: 1. Initial stage, 2. Compensatory stage, 3. Progressive stage, and 4. Refractory stage. Initial stage. The continuum begins with the initial stage of shock that occurs at a cellular level. This stage is usually not clinically apparent. Metabolism changes at the cellular level from aerobic to anaerobic, causing lactic acid buildup. Lactic acid is a waste product that is removed by the liver. However, this process requires O2, which is unavailable because of the decrease in tissue perfusion. Compensatory stage. In the compensatory stage, the body activates neural, hormonal, and biochemical compensatory mechanisms to try to overcome the increasing consequences of anaerobic metabolism and maintain homeostasis. The patient's clinical presentation begins to reflect the body's responses to the imbalance in O2 supply and demand. A classic sign of shock is a drop in BP. This occurs because of a decrease in CO2 and a narrowing of the pulse pressure. The baroreceptors in the carotid and aortic bodies immediately respond by activating the SNS. The SNS stimulates vasoconstriction and the release of the potent vasoconstrictors, epinephrine and norepinephrine. Blood flow to the heart and brain is maintained. Blood flow to the non-vital organs, such as kidneys, GI tract, skin, and lungs, is diverted or shunted. The myocardium responds to the SNS stimulation and the increase in O2 demand by increasing the heart rate and contractility. Increased contractility increases myocardial O2 consumption. Coronary arteries dilate to try to meet the increased O2 demands of the myocardium. Shunting blood away from the lungs has an important clinical effect in the patient in shock. Decreased blood flow to the lungs increases the patient's physiologic dead space. Physiologic dead space is the anatomic dead space, the amount of air that will not reach gas exchange units, and any inspired air that cannot take part in gas exchange. The clinical result of any increase in dead space ventilation is a ventilation-perfusion mismatch. Some areas of the lungs that are being ventilated will not be perfused because of the decreased blood flow to the lungs. Arterial O2 levels will decrease, and the patient will have a compensatory increase in the rate and depth of respirations. The shunting of blood from other organ systems results in clinically important changes. The decrease in blood flow to the GI tract results in impaired motility and a slowing of peristalsis. This increases the risk for a paralytic ileus. Decreased blood flow to the skin results in the patient feeling cool and clammy. The exception is the patient in early septic shock who may feel warm and flushed because of a hyperdynamic state. Decreased blood flow to the kidneys activates the renin-angiotensin system. Renin stimulates angiotensin to make angiotensin 1. which is then converted to angiotensin II. Angiotensin II is a potent vasoconstrictor that causes both arterial and venous vasoconstriction. The net result is an increase in venous return to the heart, an increase in BP. Angiotensin II stimulates the adrenal cortex to release aldosterone. This results in sodium and water reabsorption and potassium excretion by the kidneys. The increase in sodium reabsorption raises the serum osmolality, stimulates the release of antidiuretic hormone, ADH, from the posterior pituitary gland. ADH increases water reabsorption by the kidneys, further increasing blood volume. The increase in total circulating volume results in an increase in CO and BP. A multi-system response to decreasing tissue perfusion starts during the compensatory stage of shock. At this stage, the body can compensate for the changes in tissue perfusion. If the cause of the shock is corrected, the patient will recover with little or no residual effects. If the cause of the shock is not corrected and the body is unable to compensate, the patient enters the progressive stages of shock. Progressive stage. The progressive stage of shock begins as compensatory mechanisms fail. Changes in the patient's mental status are important findings in this stage. Patients must be moved to the intensive care unit if not already there, for advanced monitoring and treatment. The cardiovascular system is profoundly affected in the progressive stage of shock. CO begins to fall, resulting in a decrease in BP and coronary artery, cerebral, and peripheral perfusion. Continued decreased cellular perfusion and resulting altered capillary permeability are the distinguishing features of this stage. Altered capillary permeability allows fluid and protein to leak out of the vascular space into the surrounding interstitial space. In addition to the decrease in circulating volume, there is an increase in systemic interstitial edema. The patient may have anasarca, diffuse profound edema. Fluid leakage from the vascular space affects the solid organs, e.g., liver, spleen, GI tract, lungs, and peripheral tissues by further decreasing perfusion. Sustained hypoperfusion results in weak peripheral pulses, and ischemia of the distal extremities eventually occurs. Myocardial dysfunction from decreased perfusion results in dysrhythmias, myocardial ischemia, and possibly MI. The result is a complete deterioration of the cardiovascular system. The pulmonary system is often the first system to display signs of critical dysfunction. During the compensatory stage, blood flow to the lungs is already reduced. In response to the decreased blood flow and SNS stimulation, the pulmonary arterioles constrict, resulting in increased pulmonary artery (PA) pressure. As the pressure within the pulmonary vasculature increases, blood flow to the pulmonary capillaries decreases, and ventilation perfusion mismatch worsens. Another key response in the lungs is the movement of fluid from the pulmonary vasculature into the interstitial space. As capillary permeability increases, the movement of fluid to the interstitial spaces results in interstitial edema, bronchoconstriction, and a decrease in functional residual capacity. With further increases in capillary permeability, fluid moves into the alveoli, causing alveolar edema and a decrease in surfactant production. The combined effects of pulmonary vasoconstriction and bronchoconstriction are impaired gas exchange, decreased compliance, and worsening ventilation perfusion mismatch. Clinically, the patient has tachypnea, crackles, and an overall increased work of breathing. The GI system is affected by prolonged decreased tissue perfusion. As the blood supply to the GI tract is decreased, the normally protective mucosal barrier becomes ischemic. This ischemia predisposes the patient to ulcers and GI bleeding. It increases the risk for bacterial migration from the GI tract to the blood and lungs. The decreased perfusion to the GI tract leads to a decreased ability to absorb nutrients. The effects of prolonged hypoperfusion on the kidneys is renal tubular ischemia. The resulting acute tubular necrosis may lead to acute kidney injury. This can be worsened by nephrotoxic drugs, e.g., certain antibiotics, anesthetics, diuretics. The patient has decreased urine output and increased blood urea nitrogen, BUN, and serum creatinine. Metabolic acidosis occurs from the kidney's inability to excrete acids, especially lactic acid, and reabsorb bicarbonate. The sustained hypoperfusion in the progressive stage of shock greatly affects other organs. The loss of the functional ability of the liver leads to a failure of the liver to metabolize drugs and waste products, e.g., lactate, ammonia. Jaundice results from an accumulation of bilirubin. As the liver cells die, liver enzymes increase. The liver loses its ability to function as an immune organ. Kupffer cells no longer destroy bacteria from the GI tract. Instead, they are released into the bloodstream, increasing the possibility of bacteremia. Dysfunction of the hematologic system adds to the complexity of the clinical picture. The patient is at risk for disseminated intravascular coagulation, DIC. The consumption of the platelets and clotting factors with secondary fibrinolysis results in clinically significant bleeding from many orifices. These include the GI tract, lungs, and puncture sites. In this stage, aggressive interventions are needed to prevent the development of MODS. Refractory stage. In the last stage of shock, the refractory stage, decreased perfusion from peripheral vasoconstriction and decreased CO worsen anaerobic metabolism. The accumulation of lactic acid contributes to increased capillary permeability and dilation. Increased capillary permeability allows fluid and plasma proteins to leave the vascular space and move to the interstitial space. Blood pools in the capillary beds due to the constricted venules and dilated arterioles. The loss of intravascular volume worsens hypotension and tachycardia and decreases coronary blood flow. Decreased coronary blood flow leads to worsening myocardial depression and a further decline in CO. Cerebral blood flow cannot be maintained, and cerebral ischemia results. The patient in this stage of shock has profound hypotension and hypoxemia. The failure of the liver, lungs, and kidneys results in an accumulation of waste products, such as lactate, urea, ammonia, and CO2. The failure of one organ system affects several other organ systems. Recovery is unlikely in this stage. The organs are in failure, and the body's compensatory mechanisms are overwhelmed. Diagnostic studies. There's no single diagnostic study to determine whether a patient is in shock. The diagnosis starts with a history and physical examination. Obtaining a thorough medical and surgical history and a history of recent events, e.g. surgery, chest pain, trauma, gives valuable data. Decreased tissue perfusion in shock leads to an increased lactate with a base deficit, the amount needed to bring the pH back to normal. These laboratory changes reflect an increase in anaerobic metabolism. Other diagnostic studies include a 12-lead EKG, continuous EKG monitoring, chest X-ray, continuous pulse oximetry, and invasive and non-invasive hemodynamic monitoring. Interprofessional care. Critical factors in the successful management of a patient in shock relate to the early recognition and treatment of the shock state. Prompt intervention in the early stages of shock may prevent the decline to the progressive or irreversible stage. Successful management of the patient in shock includes 1. Identification of patients at risk for the development of shock. 2. Integration of the patient's history, physical examination, and clinical findings to establish a diagnosis. 3. Interventions to control or eliminate the cause of the decreased perfusion. 4. Protecting target and distal organs from dysfunction. And 5. Providing multi-system supportive care. General management strategies begin with ensuring that the patient is responsive and has a patent airway. Once the airway is established, either naturally or with an endotracheal tube, O2 delivery must be optimized. Supplemental O2 and mechanical ventilation may be needed to maintain an arterial O2 saturation of 90% or more, PaO2 greater than 60 millimeters of mercury, to avoid hypoxemia. The mean arterial pressure, MAP, and circulating blood volume are optimized with fluid replacement and drug therapy. Oxygen and ventilation. O2 delivery depends on CO, available hemoglobin, and arterial O2 saturation, SaO2. Methods to optimize O2 delivery are directed at increasing supply and decreasing demand. Supply is increased by 1. Optimizing the CO with fluid replacement and or drug therapy, 2. Increasing the hemoglobin through transfusion of whole blood or packed red blood cells, RBCs, and or 3. Increasing the arterial O2 saturation with supplemental O2 and mechanical ventilation. Plan care to avoid disrupting the balance of O2 supply and demand. Space activities that increase O2 consumption, e.g. endotracheal suctioning, position changes, appropriately for O2 conservation. Intermittent or continuous monitoring of SCVO2 by a central venous catheter or mixed venous O2 saturation, SVO2, may be helpful. Both reflect the dynamic balance between O2 supply and demand. Assess these values along with related hemodynamic measures, e.g. arterial pressure-based cardiac output, APCO, O2 consumption, hemoglobin, to evaluate the patient's response to treatment and activities. Fluid resuscitation. The cornerstone of therapy for septic, hypovolemic, and anaphylactic shock is volume expansion with administration of the appropriate fluid. Fluid resuscitation should start using 1 or 2 large bore, e.g. 14 to 16 gauge, IV catheters, an intraosseous IO access device, or a central venous catheter. The choice of resuscitation fluid is based on the type and volume of fluid lost and the patient's clinical status. The ideal choice of fluid is controversial. Currently, normal saline is most often used in the initial resuscitation of shock. Large volume resuscitation with normal saline can lead to hyperchloremic metabolic acidosis. Lactated Ringer solution can cause serum lactate levels to increase because the failing liver cannot convert lactate to bicarbonate. Transfusions of RBCs may be given to treat hypovolemic shock due to bleeding. Colloids, 4 to 5%, have not been shown to improve patient outcomes. Fluid responsiveness is determined by clinical assessment. This includes vital signs, cerebral and abdominal perfusion pressures, capillary refill, skin temperature, and urine output. Hemodynamic parameters such as SVV or CO are also used. Monitor trends in BP with an automatic BP cuff or an arterial catheter to assess the patient's response. Use an indwelling urinary catheter to monitor urine output during resuscitation. The goal for fluid resuscitation is to restore tissue perfusion, although BP helps determine whether the patient's CO is adequate. An assessment of end organ perfusion, e.g. urine output, neurologic function, peripheral pulses, provides more relevant data. Drug therapy. The goal of drug therapy for shock is to correct decreased tissue perfusion. Decisions on which drug to use should be based on the physiologic goal. Drugs used to improve perfusion in shock are given IV via an infusion pump and central venous line. Many of these drugs have vasoconstrictor properties that are harmful if the drug leaks into the tissues while being infused peripherally. Sympathomimetic drugs. Many of the drugs used in the treatment of shock influence the SNS. Drugs that mimic the action of the SNS are called sympathomimetic. The effects of these drugs are mediated through their binding to alpha or beta adrenergic receptors. The various drugs differ in their relative alpha and beta adrenergic effects. Many of these drugs cause peripheral vasoconstriction and are also called vasopressor drugs, e.g., norepinephrine, dopamine, phenylephrine. These drugs can cause severe peripheral vasoconstriction and increase in SVR, further risking tissue perfusion. The increased SVR increases the workload of the heart and myocardial O2 demand. It can harm a patient in cardiogenic shock by causing further myocardial damage and increasing the risk for dysrhythmias. Use of vasopressor drugs is limited to patients who do not respond to fluid resuscitation. Adequate fluid resuscitation must be achieved before starting vasopressors because the vasoconstrictor effects in patients with low blood volume will cause further reduction in tissue perfusion. Typically, if the patient has persistent hypotension after adequate fluid resuscitation, a vasopressor, e.g., norepinephrine, dopamine, and/or an inotrope, e.g., dobutamine, is given. The goal of vasopressor therapy is to achieve and maintain a MAP of greater than 65 millimeters mercury. Continuously monitor end organ perfusion, e.g., urine output, level of consciousness, and serum lactate levels, e.g., every 3 hours for the first 6 hours, to ensure that tissue perfusion is adequate. Vasodilator drugs. Patients in cardiogenic shock have decreased myocardial contractility, and vasodilators may be needed to decrease afterload. This reduces myocardial workload and O2 requirements. Although generalized sympathetic vasoconstriction is a useful compensatory mechanism for maintaining BP, excessive constriction can reduce tissue blood flow and increase the workload of the heart. The reason for using vasodilator therapy for a patient in shock is to break the harmful cycle of widespread vasoconstriction, causing a decrease in CO and BP, resulting in further sympathetic-induced vasoconstriction. The goal of vasodilator therapy, as in vasopressor therapy, is to maintain the MAP greater than 65 millimeters of mercury. Monitor hemodynamic parameters, e.g., CVP, CO, SCVO2, SVO2, SVPA pressures, and assessment findings so that fluids can be increased or vasodilator therapy decreased if a serious fall in CO or BP occurs. The vasodilator agent most often used for the patient in cardiogenic shock is nitroglycerin. Vasodilation may be enhanced with nitroprusside or nitroglycerin in non-cardiogenic shock. Nutritional therapy. Protein-calorie malnutrition is common because of hypermetabolism. Nutrition is vital to reducing mortality. Enteral nutrition, EN, should be started within the first 24 hours. However, full calorie replacement is not recommended for previously well-nourished adults early in a critical illness. Start the patient on atrophic feeding. This is a small amount of EN, e.g. 10 milliliters per hour. Early EN enhances the perfusion of the GI tract and helps maintain the integrity of the gut mucosa. Advanced feedings is tolerated and as prescribed. Parenteral nutrition, PN, is used only if EN is contraindicated. Weigh the patient daily on the same scale, usually the bed scale, at the same time of the day. If the patient has a significant weight loss, rule out dehydration before adding more calories. Large weight gains are common because of third spacing of fluids. Therefore, daily weights serve as a better indicator of fluid status and caloric needs. Serum protein, total albumin, prealbumin, BUN, serum glucose, and serum electrolytes are all used to assess nutritional status.